So, may I call upon Dr. Sanjay Kumar Shah. He will be speaking on beta cell preservation. I hand over the mic to Dr. Shah.
Good evening, chairpersons. Good evening, seniors, teachers, and colleagues. I hope you can see my slides and perhaps hear me as well. You can. Thank you. Thank you for that. Okay. So the next 15 minutes, what I'm going to essentially share with you, sirs, is talk about beta cell preservation. So while we have struggled to control blood sugars and treat diabetes, as Dr. Joshi mentioned to you very nicely, but can we do better, or do we have the tools to do better as well? And the holy grail in diabetes management, I must congratulate Dr. Jotideb to give me this topic, which is truly something which stimulates your brain and perhaps helps you to understand diabetes better as well. So it's the holy grail that we want in diabetes management, and we look forward to that in terms of beta cell preservation. Now, beta cell function in type 2 diabetes, we have been talking about this for a long time. Can we preserve the beta cell? Because it is the beta cell dysfunction which is a critical determinant of type 2 diabetes. We'll also briefly look at the beta decline study as well to give us some answers. Now, beta cell dysfunction is much more common in Indian patients, and perhaps it's even more important that we perhaps learn the art of preserving beta cells, if it was possible, with the tools we have today. We look at the anti-diabetic therapies that are presently available and what they perhaps do to beta cells. We'll have a glimpse of that. And then perhaps end by some data from DPP-4 inhibitor vildagliptin and its ability to preserve beta cells is what we look at, essentially being the flag bearer of DPP-4 inhibitors as a class, and basically by some key takeaways and conclusion. So, beta cell function in type 2 diabetes, we all are aware that type 2 diabetes is widely considered a chronic progressive disease with no disease-modifying treatment or cure. That's the understanding with which I grew up while I was training. And I think over the years, perhaps we've accepted that as part and parcel of practice. Over time, blood glucose rises despite treatment escalation as beta cell function progressively declines. And that is something which we perhaps...
I'm just interrupting you. Your
Sure.
slides are not sharing, sir. Just not moving. The slides are not moving, sir.
Okay, let me try again. Stop share. Share again. Can you see my slide now?
No, sir. Again, sir, just do it.
Can you see it moving?
Not moving, sir. Again.
Still not moving. Okay. Let me try again. Can you see my slide now?
Yeah, sir. I just now moved, sir.
And
Share option.
Yes, sir. It's visible. Please move, sir. Yes, it's moving, sir. Yes, yes.
It's
Now
moving
it's
now.
okay, sir.
okay, thank you for that. So
Okay, sir. Thank you.
the problems of technology. Thank you for pointing it out. So as I was mentioning, we are all in search for the holy grail with respect to beta cell preservation per se. So we're looking at, can we preserve beta cell? We look at beta decline study, and then we look at several of the anti-diabetic therapies and its effect on beta cell function. And then perhaps end by looking at DPP-4 inhibitors, particularly vildagliptin data, as a flag bearer of DPP-4 inhibitors in the preservation of beta cells, and end by some key takeaways and conclusion. Now, type 2 diabetes is widely considered a chronic progressive disease with no disease-modifying treatment or cure. And that's perhaps what I grew up with as in my training as well. And over time, blood glucose rises despite treatment escalation as beta cell function progressively declines. And that is essentially what our patients experience as well. They start off with no medication, only lifestyle changes. Then they start off with 1 tablet a day. It moves on to 2 tablets a day, then to 3 tablets a day, and then perhaps injectables if they fail. So this is how people have experienced their management of diabetes. However, more recently, studies have demonstrated that restoration of normoglycemia is possible after bariatric surgery, after very low calorie diets or intensive insulin therapy, okay? So there's some hope. The intensive insulin therapy have raised the possibility that declining beta cell function in type 2 diabetes may be halted, even though it may be temporary as far as we know for now, or reversed, or even perhaps preserved. So we'll look at what drugs can do later on. I think the essential element, apart from the many sort of pathophysiologic defects in type 2 diabetes, one aspect is insulin resistance, and the other aspect is the progressive beta cell dysfunction or failure per se. So it's only when your beta cells fail to compensate for the insulin resistance, you start developing prediabetes. And then by the time you have a 50% or sort of apoptosis roughly of your beta cells, you still develop type 2 diabetes. So before all this actually happens, the insulin resistance actually is driven by the elevated plasma free fatty acids. So one of the hypotheses is basically lipotoxicity affects insulin resistance in the liver as well as in the muscle per se. So it's only when your beta cells basically fail to produce enough insulin, you then develop diabetes per se. Now, this decline in beta cell function starts several years before the diagnosis of diabetes. And the Whitehall study, okay, demonstrated that gradually increasing fasting plasma glucose levels over the last 10 to 12 years is what is happening prior to the diagnosis of type 2 diabetes. And that is shown very nicely in the chart on your bottom left-hand side, where you see that there's only a gradual increase in basically fasting plasma glucose. But over the last couple of years, this trajectory changes dramatically. And 2 years before diagnosis, there's an acute beta cell decompensation. And basically that essentially seems to result in basically diabetes per se. Once a patient develops diabetes, however, the inexorable decline of beta cell function continues. As you can see on your right-hand side of this in the slide, the right bottom right, okay? And partly this is attributed to our attempt to treat failure at each stage of a patient with diabetes. As Dr. Joshi early on mentioned, that perhaps you need to attack patients early on with double or triple drug therapy. Similarly, a step-by-step or sequential increase in medication essentially results in some amount of treatment inertia. Okay, you're waiting for your patient to fail, and that failure is then treated with another, so from lifestyle which fails to monotherapy which fails to dual therapy which fails. So that each time you're treating failure, there is an amount of time where basically you have the area under the curve where there is a reasonable amount of glucotoxicity and lipotoxicity, which actually fuels the fire for which perhaps results in much more beta cell decline as well. Okay, so can we halt all that is essentially the issue. There's data from this study, the beta decline study. So if you look at basically patients who are not well controlled, A1Cs of more than 7%, which are in orange, the bar diagram, and those with an A1Cs of less than 7%, which are in blue, you can see for yourself, this is the bar diagram of the pro-insulin and insulin ratio. So patients with a poor control of diabetes with an A1C greater than 7%, there is evidence to suggest that the endoplasmic reticulum, where the insulin is produced in the beta cells, is stressed, okay? It's becoming dysfunctional, and there's more pro-insulin basically being released. Some of this is also being explained by lipotoxicity in preference to serum, in preference to insulin levels. So the number of subjects with out of target A1Cs of more than 7%, there is evidence to suggest there is much more stress to the beta cells and more beta cell dysfunction. And all this basically contributes to progressive beta cell failure and apoptosis as time goes by. Now in India, we not only have insulin resistance, but we also have our population, there's a rapid decline of beta cell function as well. So it's extremely important if we look at ways to preserve the beta cells, because we are just most susceptible to beta cell failure. We are aware of the Far Eastern studies from Dr. Wu looking at insulin basically resulting in rescuing of beta cell therapy in somebody who has got acute decompensation of blood sugars. But the takers for this kind of treatment are far few because it is the injectable therapy. You may have to perhaps educate your patients. I've done so in my clinical practice with really reasonably good results. The other option essentially is giving step-by-step oral hypoglycemic agents. However, unfortunately, metformin doesn't have the ability to preserve beta cells as much as perhaps other drugs. And definitely even sulfonylureas also seem to fail in terms of preservation for beta cells per se. So we need to move on beyond metformin, if it is possible, reasonably quickly to prevent that inexorable decline of beta cells in Indians. So beta cell preservation in early courses of disease is important for successful diabetes treatment and prevention and management of diabetes in Indians. So what causes or what is responsible for the beta cell apoptosis? And here there's a slide which is perhaps explains you very nicely in terms of on your left-hand side, you can look at glucotoxicity, you can look at lipotoxicity, you can bear with me. So you got glucotoxicity, lipotoxicity, inflammation, islet amyloid, insulin resistance has some effect, but very little. It's largely, again, incretins per se, the alpha cells as well. So if you look at what drugs can perhaps contribute in terms of preserving beta cells, would be drugs like insulin, as I have mentioned early on. Incretin-based therapies per se can do so. TZDs can do so as well, so thiazolidinediones. The thiazolidinediones have the ability, again, to reduce lipotoxicity as well. Incretins can do that too, as well as insulin as well. And then you have drugs like metformin, which can reduce some inflammation. Incretins even reduce basically islet amyloid along with the thiazolidinediones. And then the incretin-based therapies addressing alpha cell defect, which contributes to improvement in beta cell function as well. So the incretin-based therapies have several different mechanisms by which it can protect and improve the function of beta cells per se. It favors the maintenance of beta cell mass. I won't go as far as saying that it stimulates regeneration, proliferation, or neogenesis, but perhaps it enhances the resistance to apoptosis. The other aspects of beta cell preservation is largely seen in animal studies. but in terms of clinical studies in human beings, there is definitely some resistance to apoptosis in patients who are on incretin-based therapies per se. So that brings me to the role of DPP4 inhibitors like vildagliptin in the preservation of beta cells. We have evidence to show very nicely that as monotherapy, vildagliptin and perhaps other DPP4 inhibitors as well significantly improve HOMA beta. When you use it as an add-on therapy to other agents, particularly metformin, again, it shows significant improvement in HOMA beta, while it has very little effect on HOMA IR. So the first two, as HOMA beta is nothing but a measure of insulin secretion per se, while HOMA IR essentially is looking at insulin resistance. So DPP4 inhibitors have very little effect on insulin resistance. But the use of this drug basically helps your beta cells to function better and preserve them as well. So here is data with respect to improvement to beta cell function with vildagliptin. Now there is improvements in the acute insulin response to glucose, AIRG, and the sort of insulin sensitivity index, SI, as well as there's an improvement in disposition index as well, all a measure of beta cell function as well as insulin secretion. So the dense orange bars are essentially vildagliptin 50 milligram once a day, vildagliptin 50 milligrams twice daily, again is the hazy orange bar, but the very light pink bar essentially is placebo per se. So you can see for yourself that the acute insulin response to glucose, the insulin sensitivity index, the disposition index, all are improved with the use of basically vildagliptin per se. And on your right-hand side, measures of beta cell function with both vildagliptin 50 milligram once daily as well as vildagliptin 50 milligrams twice daily. There is essentially an improvement in the area under the curve with respect to insulin secretion rate compared to glucose per se. So again, giving you the insight in terms of there's an enhancement of beta cell function with the use of vildagliptin and metformin compared to when you use placebo and metformin, which is shown in gray. So there's a 5 times enhancement of beta cell function when you use vildagliptin and metformin. The improvement in beta cell function with vildagliptin and metformin in newly diagnosed patients, which was shown in the VERIFY study. Again, the VERIFY study showed us very nicely how the combination of the two, vildagliptin and metformin, delayed failure in terms of diabetes management by nearly twice the time. So compared to perhaps metformin, which perhaps failed in roughly 2.5 years, vildagliptin with metformin combination continued to basically work for your patient up to upwards of 5 years per se. Now, at the end of that period 1, okay, which was basically when you have started to fail your blood sugar control, the vildagliptin metformin combination showed you a very nice improvement in HOMA beta, which is shown in orange here compared to metformin alone. Again, vildagliptin and metformin combination therapy showed improvement in beta cell function compared to metformin monotherapy per se. So if you look at the other indices, there's definitely an improvement in hemoglobin A1C, which was statistically significant, p-values of less than 0.00001. Fasting sugars, again, when you use vildagliptin again, you have strongly positive. The HOMA IR, it is in the right direction.
1 minute left. So
yeah, it is in the right direction,
yeah.
But again, it's still favorable. And HOMA beta, essentially, there's then very strong in terms of insulin sensitivity and insulin secretion per se. With respect to beta cell secretory capacity following 1 year of treatment on drug, the orange bars showing you increased insulin secretion. Off drug, all that comes down again. On-drug disposition index, again, orange bars. So again, insulin secretion is far better when your patient is on vildagliptin compared to when they are not. Again, suggesting that vildagliptin has benefits in terms of improved beta cell function as well as preservation. So I come to my last couple of slides. The key takeaway from my presentation per se, vildagliptin improves beta cell function. There's some improvement in insulin sensitivity, but the most important benefit is improved beta cell function. It improves A1C, fasting plasma glucose, and postprandial glucose per se, giving you a hint, clinically at least, there's an element of beta cell preservation with the use of DPP-4 inhibitor vildagliptin. So in conclusion, type 2 diabetes is associated with progressive loss of beta cell function. The interventions that preserve beta cell function have improved the durability of glycemic control. And the Verify study shows you quite nicely with respect to that. Studies suggest that several treatment options exist. If delivered early in the course of type 2 diabetes, it can preserve beta cell function in the short and long term. And these drugs include TZDs. Unfortunately, it has other side effects like fluid retention, maculopathy, fractures per se. We've talked about DPP-4 inhibitors at great length. The Verify study is a great example. The GLP-1 analogs, the LEADER trial, again showed you quite nicely. Unfortunately, it has to be used as an injectable. Insulin has the same drawback. You need to use an injectable. And to some extent, even the SGLT2 inhibitors. The heart failure study showed you, particularly with dapagliflozin, that there's a reduction in patients developing diabetes. Unfortunately, there are other issues with respect to SGLT2 inhibitors because it essentially stimulates alpha cells, and perhaps you need the DPP-4 inhibitor on board to give you the benefit in terms of improvement of beta cell function per se. However, some reduction in glucose toxicity definitely helps with SGLT2 inhibitors. For the time being, I've shown you some data with respect to vildagliptin, which is flag bearer of a DPP-4 inhibitor due to the paucity of time, its ability to improve beta cell function and perhaps preserve it too for our patients with type 2 diabetes. I'll stop here. Thank you for your patient hearing. Thank you once again for giving me this opportunity.